All right, good afternoon, everyone, and thank you for joining us for another one of our free educational seminar. Today we have Dr. Kostos, a rheumatologist, and the section today is evidence-based diagnosis of lower back pain. Our Dr. Kostos is a rheumatologist who specializes in all aspects of general rheumatology, including arthritis, mechanical joint problems, soft tissues, and particular problems. His skill in practical procedure, including epidural injections, joint aspiration injection, and conducting EMG as well. His main interests include musculoskeletal medicine, focusing on spinal and peripheral joint problem and their interactions with compensation issues. He has been working with us for a couple of years now. Now, may I ask that you all please remain muted so noises from your home or workplace does not affect the quality of the recording. You will be able to unmute and ask questions at the end of the presentations, or you can type your question in the chat box if you need to go or don't want to speak up. The recording will be sent out to you within a day or so. Thank you so much for giving your time today to deliver this section for us, Dr. Kostos. Over to you now.
Hello, hopefully everyone can hear me. So, thank you for that introduction, Sophia. I would just sort of be a bit conversational today because there's a number of highly technical issues relating to what I'm going to say. But as I said, I'm going to keep it fairly conversational. I'm going to be very happy to answer questions at the end. But just to give you a bit more of my background, I actually got into rheumatology through sports medicine. Second year after graduation, I actually ended up being one of the doctors at a VFL football team, as they were in those days, and decided that I wanted to learn more about joints. And then I just happened to be at the Repatriation Hospital in Melbourne, which was one of the two training positions in Victoria. And we did a lot of musculoskeletal medicine, a lot of back pains. I'd learned to do translumbar epidurals. We were doing those on a regular basis. And then I was lucky enough to get a job in London at St Thomas's Hospital. Now, if any of you know London, St Thomas's is the hospital across the river from the Houses of Parliament. So we had a very nice view from our 9th floor ward. But the interesting thing was that the rheumatology unit at St Thomas's was started by a chap called James Syriacs, and he actually pioneered the use of epidurals. So I ended up doing a lot of epidurals as well in London. But because we didn't have beds to admit patients to, we were doing the epidurals in outpatients, and patients would lie down for half an hour and then go home. The other thing that Sophia mentioned was that through another quirk of fate, the rheumatology unit at St Thomas's did the nerve conduction studies for the hospital. So I learned to do nerve conduction studies, but given my lack of knowledge, I was just confined to the carpal tunnel syndromes. But I have had an interest in carpal tunnel syndrome ever since. So that's where I found myself. And it was interesting, when I got back to Australia in late 85, early 86, it was at the height of the RSI epidemic. So there was a big call for people involved with musculoskeletal medicine to try and sort things out. And I managed to find another mentor called Norton Hadler from the States, who came to Australia in 85 and predicted that the epidemic would be over in a few years, which proved to be exactly correct. So he's been a tremendous sounding board for me as well. So can we have the first slide, Sophia? So what I'm just going to do when the slide comes up is just go through what we look for with the history. So obviously, whenever you see anyone, the history is important. But there are no features of the history that can reliably determine the cause of back pain. So I'm specifically talking about back pain. I'm not talking about sciatica, because that's an entirely different area. So the only time the history is useful is determining if there are psychosocial factors, the so-called yellow flag.
I've just been logged into a training thing.
Oh, okay. So the psychosocial yellow flag. So what we're looking for is, quite florid descriptions of pain. The pain's all over the body, pain same day and night. And increasingly what I'm finding is that in this day and age, there's bullying and harassment, which I colloquially label as the new RSI. We're also looking for serious conditions that warrant further investigation. So can we have the next slide, Sophia? So with the yellow flags, people have a number of attitudes and beliefs about low back pain. And this is very important because, when they go to the doctor and they say they've got back pain, the doctor takes an x-ray and says, oh, you've got a lot of wear in your spine. And that patient would say, oh, how did I get that? Oh, well, it must be your work, which is completely false. Patients often have very fixed views about their diagnosis. They've obviously, a lot of cases, have been misinformed about the diagnosis, and they've already undergone treatments that have no benefit to them. Compensation issues are extremely important. I mentioned Norton Hadler. Norton says that when you make a compensation claim, you cease to be a patient and you become a claimant, and that becomes very important. Patients' behaviour, emotions, interaction with work and family are all issues that can be important. And the other thing is that we have to be wary of is, you're in the business of getting independent medical reports. And Norton says that if you're a claimant, you've actually got to prove that you're sick, because that's your ongoing entry into compensation. And he says if you have to prove you're sick, you can't get well. So all of these things that that I like to consider as what we call the yellow flags. What you'll find is that surgeons are not interested in yellow flags. They don't ask anything about the patient. Their focus is on the back, not the patient. So if we have the next slide, Sophia. So what are we talking about, the red flags? So we see a variety of inflammatory diseases, and some of these diseases affect the spine. This is called ankylosing spondylitis, and this typically affects younger males, but the typical history of inflammation is pain at night, stiffness in the morning, and actually when they start to move around, their stiffness improves. But unless you ask for this history of inflammatory pain, you will miss the diagnosis. Over the years, I've frequently seen many patients where the diagnosis of ankylosing spondylitis is missed. It's important to know that in the olden days, we used to use X-rays to determine the changes that we're looking for, particularly in the sacroiliac joints. Excuse me. But we now recognise an entity called non-radiological spondyloarthropathy, where these inflammation changes are only apparent on MRI scans. But you need to ask specifically for these things to be looked for because they don't show up in just a straightforward MRI scan. Obviously, we're looking for cancers, so the elderly, previous history of malignancy, illness, weight loss, and the failure to improve with treatment. So all of these raise concerns. And over the years, I've picked up quite a few cases. Myeloma, multiple myeloma is a condition that typically affects the spine. I've recently seen someone where lytic lesions were noted on the CT scan, but they were described in the findings, but they weren't included in the conclusion. And they were missed for over a year before I saw the patient and said, well, these lytic lesions are the cause of his problem and he needs to have urgent intervention. Next slide, Sophia. Infection. So I've certainly seen cases of this, and we look for, again, this inflammatory pain, which is worse at night, systemic symptoms, so people are unwell. They often have, they may have a temperature, they lose weight, and at this day and age, we're looking for also anything else that could be a source for infection, such as body penetration. So studs and things, obviously tattoos, so anything that could be a focus of infection. We're also looking for fractures, and invariably most fractures occur with trauma, but the trauma can be minimal in patients over 50 who have osteoporosis. And we know that osteoporosis and fractures are more common in patients who use cortisone, so prednisolone. They might have asthma or something like that, which they're on cortisone for. So again, most of the surgeons never ask about these problems. They're just purely focused on the scan. Next slide, Sophia, thank you. So you would think the examination could help, but it doesn't. The physical examination cannot provide a diagnosis of low back pain. People talk about certain tests or patterns of movements, but all of these manoeuvres and tests lack reliability, specificity, or both. So bending the spine one way or another cannot tell you whether they've got a disc problem or a facet joint problem. That's a complete fallacy. Now, what can the examination tell you? Well, the examination can certainly tell you if the spine is stiff. And we're also looking for features of abnormal illness behaviour and non-organic signs. So these were first described by Gordon Waddell, a Scottish orthopaedic surgeon. So sometimes they are known as Waddell's non-organic signs. So what are we looking for? So we're looking for people who, are paralysed. They can't move. They have tenderness along the entire length of the spine. We also do a couple of other manoeuvres. So we rest your hand on top of their head and just put some gentle pressure. Now, even if someone has a fracture or a cancer in their back, that doesn't cause pain. But in patients with non-organic signs, that causes pain. We also do a test called simulated rotation, where we stand them up, keep their arms by their side, and then get them to twist. So they're not moving their spine at all, they're just twisting the hips, and that can cause pain. Sometimes when you're doing the rest of the examination, they're lying down, they can't lift their legs up, yet they can sit upright with their legs extended in front of them. So there's all these sorts of things that establish whether there's together with the yellow flags of the history, suggest that these people have a diagnosis of a chronic pain syndrome, which are largely influenced by psychological and social factors. Next slide, Sophia. So let's go on to the investigation. So in the old days, X-ray used to be the only thing available. We've obviously got a variety of scans now. There's actually no indication to have an X-ray unless you're concerned about a red flag condition, because we can see abnormalities with no clinical significance, such as a spina bifida occulta, which is a congenital abnormality, or a transitional vertebrae with a spinous process attached to the iliac crest. We can see abnormal findings with questionable clinical significance. In other words, if you X-ray people my age, we've all got disc degeneration and osteoarthritis. Spondylolisthesis is where one vertebrae slips forward on the other. But studies show that you're less likely to have pain if you have a spondylolisthesis. So this is not very helpful. And then, of course, if the X-ray is abnormal, you see a fracture, or these usually relate to, or other conditions, these usually relate to the red flag conditions. So the red flag conditions certainly need investigations. Otherwise, someone with just common garden back pain, the X-ray is basically a waste of time. Next slide, Sophia. So a lot of GPs would just go straight to the CT scan. And the evidence for this, you can see the reference 1986 when we first started using CT scans. It was clear that abnormalities are frequently seen in asymptomatic individuals, and the incidence of abnormalities actually gets worse as you get older. Not surprising. So there's disc degeneration, disc bulging or herniation, osteoarthritis, but these abnormalities are frequently seen in asymptomatic individuals and can't be assumed to be the cause of the pain. So CT scans do not play any role in the diagnosis of low back pain. But what you will see is that a GP does a CT scan and then writes that the diagnosis is L45 disc bulge. So as soon as you see that, you know the GP probably hasn't taken a history, probably hasn't examined the patient, and it's just used the result of the CT scan as a diagnosis. And this is non-evidence based. If if I was giving you advice, I'd say, well, you reject that on the basis that it's a non-evidence-based diagnosis. Next slide, Sophia. So the same situation applies with MRI scans. All of the abnormalities we've been talking about are seen in asymptomatic individuals and increase with increasing age. And all of this evidence has been available since the early 90s. But, you know, exactly the same situation applies with MRI scans to CT scans. If a GP does an MRI scan, and in particular a surgeon, they will just say the diagnosis is the appearance of the scans. And you know that's a non-evidence-based diagnosis. However, the MRI scan is the best screening test for the red flag conditions that we discussed earlier. Next slide, Sophia. So there's been a lot of research into can the MRI scans or any other tests that we do predict the future development of low back pain. And David Borenstein, he's done a lot of work in this area and published widely. And the degree of changes on the MRI scan in asymptomatic individuals didn't predict whether these individuals would develop low back pain at some stage in the future. So the MRI scan can't even tell us that. So they have limited use in diagnosis and predicting what is going to happen in the future. The issue that you might get involved in is whether someone can go back to work, and people talk about, oh, well, they've got a lot of change on the MRI scan, and they shouldn't do heavy work. Well, it's not predictive. So they can't make that statement. Next slide. Now, medial branch blocks. Now, this has become a huge industry in the pain clinics. So no doubt you've had lots of requests for medial branch blocks, and they're usually from pain physicians. Now, you have to understand that pain physicians don't treat patients. Pain physicians have made pain the problem, and they're not interested in patients with pain. So they don't really have any feel for musculoskeletal medicine. They're just strictly proceduralists, and they will attempt to treat any abnormality. So the current trend for these physicians, and also for a lot of surgeons, is to do a bone scan with SPECT-CT. And they think that this can identify patients that have zygohypophyseal or facet joint pain, because there's increased uptake in the joints. What they don't understand is the increased uptake occurs in people with osteoarthritis in the joints because they have extra bone. And a chap called Friamouth did a study looking at trying to correlate the results of bone scan and SPECT-CTs with medial branch blocks and found no correlation. So if you see a request coming through from a surgeon or a pain specialist saying, oh, we've got SPECT-CT changes, we want to do medial branch blocks, you know that they don't understand the evidence. So why do we do medial branch blocks? It was found that just injecting the facet joint couldn't actually confirm that patients had facet joint pain. And this is because these joints are very tiny, and you'll find that people were injecting a mil of local anesthetic and a mil of cortisone, and it was going everywhere. So what was then thought of was these medial branch blocks, because each facet joint is supplied by a superior medial branch and an inferior medial branch, and these nerves do not supply any other structure. So by blocking the two nerves and relieving the pain, you would think is pretty good evidence that that joint is the cause of pain. Unfortunately, that's not the case. We know that a single block can produce a 40% false positive rate. And some of the earlier studies were done very nicely with short-acting local anesthetic, long-acting local anesthetic, and saline blocks as a control. So if you've got a couple of hours relief with the short-acting local, a couple of 4 to 6 hours relief with the long-acting local, and no relief from the saline, it was only in those circumstances that these blocks that was considered to be positive. Now, the reason they want to do the blocks is that then that leads into denervations. You probably had 1 million requests for facet joint denervations. If you do the blocks properly and only block a single joint with the control block, and you found that that joint is the source of pain, denervation should relieve the pain completely. And there was a rheumatologist in Sydney, Les Barnsby, who did a lot of work on the neck. And this was his only outcome measure, complete relief of pain. And when the pain started to come back in 12 to 18 months, he did the denervation again and then relieved the pain again. So unfortunately, what happens in the pain clinics is that the anaesthetists do multiple blocks because these attract multiple fees. And they will say, oh, there's a, 2 or 3, improvement in pain scores. Well, that's a placebo response. But, as I said, you'll probably seen many requests on this. And unfortunately, as I said, pain doctors make pain the disease, and they're not interested in treating patients. So do we have the next slide, please, Sophia? So this just shows, this is another Sydney rheumatologist, Anthony Schwarzer. He did a lot of work on these, and he also had some sacroiliac joint blocks, which we'll come to. So obviously, if you've got arthritis, you're going to have pain as you get older anyway. So you can see amongst older workers, it was much higher than younger injured workers. Next slide, Sophia. And he also did the sacroiliac joint blocks, and he proved that just an ordinary local anaesthetic block has a 30 to 40% false positive rate, and this is why he said that control blocks must be done. So yeah, we certainly do. If the blocks are done properly, we certainly do see an incidence of people with sacroiliac joint pain. You'll see physios and chiropractors who reckon they can diagnose sacroiliac joint pain on the basis of the examination. They can't. So the only way you can be certain is by doing these proper studies. Next slide, Sophia. So in summary, the history and examination alone cannot determine the cause of low back pain. All of the investigations need to be undertaken with caution because they cannot determine the cause of back pain. Although, as I said, the MRI scan is the best screening test for red flag conditions. All of these blocks must be done with strict methods to obtain meaningful results. But as I said, the pain doctors aren't interested in meaningful results. They just want to move on to the next procedure. So just before I finish, I just want to say a few things about surgeons. Most orthopedic surgeons and neurosurgeons and occupational physicians have no training in musculoskeletal medicine. Surgeons are trained to operate, and invariably they will look at the test results and use that as the diagnosis, such as we talked about before, L4-5 disc bulge. Now, as I said, I'm not talking about sciatica, I'm just strictly talking about back pain, because that's the most common thing we see. So I'm not sure if you understand that what the surgeons do is say, oh yes, you've got a disc bulge at this level, we need to do a fusion. So first of all, the surgeon doesn't know whether that disc is the cause of pain. Secondly, we know that spinal fusions are non-evidence-based procedures. They have no benefit at all. Certainly sometimes the surgeons get lucky and they may have a successful result, but invariably they don't. What then happens is they come back to the surgeon and the patient says, I've still got my pain, doc. And the surgeon says, well, no, my operation's been successful, but better have another look at your spine. So they do another scan and they say, oh, you've got a bit of wear at the disc above. Perhaps we need to fuse that as well. So this is what happens. And then after a while, when the surgeon is starting to duck for cover, he sends the patients off to the pain clinics and said, my surgery's been successful. Sorry, I can't help you anymore. Just to give you an idea of the extent of this problem, I have been asked to see someone next week, and I was just having a look at the file. This patient's had long-standing back pain for about 6 or 7 years, already had 2 procedures on his back that have failed, and the surgeon's done another scan, and now he's found that there's disc degeneration osteoarthritis at L1-2 and L2-3. So the surgeon has proposed to do a spinal fusion from T10 to the pelvis. I've never heard such an extensive procedure being done, and it's being done purely on the basis of the scans. So I've been asked to offer an opinion as to whether that is an appropriate procedure. Well, hopefully you can see from what I've said today. I mean, at times you just shake your head in disbelief. So there are some, just to put things in perspective, there are some surgeons that I would trust to do back operations, but yeah, often you have to find the right surgeon, and I don't mind discussing the situation with the surgeon because, as I said, I have a few that I use, and we make sure we get the right procedure done. But generally the surgeon's lack of knowledge is mind-boggling, and you know, if the general public knew what was going on, you know, there'd be a kerfuffle. But unfortunately, once you're a surgeon, you've sort of got this halo above your head and you're virtually untouchable. So I hope I've been a bit provocative and might stimulate a few questions. So happy to have a crack at anything you want to ask.
All right, everyone. Have everyone have any questions to ask? You can unmute yourself by clicking the small microphone at the left down side on your screen. Okay, I don't think they have.
All right. Well, let me say, some people say, well, what do you put when you're asked to see a back pain? I would say once I exclude non-organic conditions, if they've got Waddell's signs and you know, yellow flags on the history, I would call them a chronic pain syndrome, which means they have ongoing pain in the absence of any identifiable physical abnormality. I then said that chronic pain syndromes relate to psychological and social factors with the role of inherent personality traits, previous life experiences, attitudes and beliefs, and the adaptability to cope with anxiety and stress becoming increasingly appreciated. Often that stress comes from what is perceived as bullying and harassment. We also find a lot of these people have a history of physical or sexual abuse, particularly in childhood. But I sort of rarely delve into that area. But a lot of the time that I am doing IMEs, they've been to a psychiatrist who's identified those factors. So if someone therefore has a genuine back problem, what do I say? Well, I say they often have a back pain or strain, the nature, the cause of which cannot be identified. So if they have a history of an injury and they present genuinely, there's no histrionics on the examination, then I'm prepared to accept that as a genuine problem. But can I make a diagnosis? The answer is no in the vast majority of cases.
All right, Doctor. Actually, we have two questions from Ms. Alice Wensley in the chat box. First is she's wondering what you would recommend for the best evidence-based practice for the diagnosis of back pain, particularly with workers' compensation claims.
Well, I've just given you the evidence, and the majority of cases, whether they're workers' compensation or not, we can't diagnose the cause of back pain. So that's why I was just saying, well, what I do in my situation is I try and exclude the chronic pain syndromes and try and find the genuine people. Now, fortunately, I've been doing this for well over 30 years, so I've sort of got a good, sometimes you just get a good idea, the look on their face, the way the history is presented. Often you get the vibe very quickly as to what's going on here. But as I said, often in these situations, there's a lot of other things going on. As I said, bullying and harassment becomes an increasing problem. You know, adjustment disorders are frequently diagnosed. And the other thing is often these people have a long history of pain. And as I mentioned at the start, my mentor Norton Hadler says, if you have to prove you're sick, you can't get well. And if you're sending these people to IME, they need to continue to, present as injured in inverted commas to maintain their compensation payments. So it's not a straightforward issue. And as I said, I'm only giving you sort of a brief synopsis of what I've learned over the last 40 years.
Yeah, thank you, Doctor. Actually, there was the second question from Miss Alice as well. She said that she worked in the health industry and she often hear about nurses' back, and she would love to hear your thoughts on the general wear and tears and back pain generally felt by nursing staff who have been working for more than 20 years.
Okay. Well, wear and tear is a fallacy. Where back problems, osteoarthritis and disc degeneration do not result from wear and tear. Sydney rheumatologist Philip Sambrook did MRI studies on twins, looking at the neck and the back. Some of these twins were, one worked in manual activities, one was sedentary, and the conclusion was that 80% of what we see, so disc degeneration, osteoarthritis, and other changes in the spine, are genetically determined. So they're hereditary. So this concept of wear and tear still being spouted by the surgeons is a fallacy. So does manual work cause things to wear? No. Actual physical work is good for spines. So so this, but as I said, unfortunately, the concept of wear and tear is still with us. It often starts because they say, oh, your joint's worn out. Well, why is it worn out? Oh, well, because of your work. It's a complete fallacy.
Yeah. All right. I hope that the answer from Dr. Kostos can address your questions, Ms. Alice. And
probably raises more questions than
yeah. Everyone, does anyone have any questions for him? Yeah. All right. So thank you for that, Dr. Kostos. It seems like you cover everything, and I think we need to wrap it up here. Thank you for sharing your expertise with us today, and thank you everyone who attended today as well. Have a great rest of the day, and we'll look forward to seeing you at our next seminar. Thank you very much. Goodbye.
Thank you all for attending.